Okay. One time I had a patient, and he recently just had the amputation of his foot. He was on a PCA morphine pump, and they've given him all of their pain medications, but nothing was really working. And I forget, this may have been like my first year, and I was still learning about pharmacology. And I remembered from my pharm class that gabapentin could be used for phantom leg pain. So even the nurse like couldn't really figure out like what else to do because they've kind of given him all the different pain meds, the highest, and nothing's been really working. So I suggested to my nurse that would gabapentin be an alternative for this pain medication since nothing else has been working. And after that, after we checked back with him, after we administered the medication, he said it helped a lot. And on top of that, I would say I did like something small, as in like just put up his favorite music, just because I know that little things like that can ease the pain for a bit. So I think that's the time I would kind of critically think or a plan of care.
So I did have a patient who came in because her AV fistula had clotted. The patient did not have any cardiac issues or a history of cardiac problems, but I heard in handoff report that the tele tech had read that she had Brady AFib. So as the morning went on, I noticed that um, I was wondering, what was going on with that patient in terms of like her dysrhythmia. It was cardiology going to go see her. So I was looking at the monitor and I noticed that she also had an episode of a flutter. So I told the nurse and I asked him to verify. I was like, is this a flutter that's showing on the monitor? And we found that the patient was actually having like episodes of Brady AFib and episodes of a flutter like back and forth. So he checked the progress notes and saw that in the ED, she had an episode of AFib, and the note had said that cardiology was going to follow up with her, but no one had since she was admitted to the hospital. So the travel nurse that I was shadowing, he messaged the doctor to follow up about that, and the cardiologist got to go in and see the patient. So I had this one, I don't know if this fits, but I had this one patient who was on our floor for a GI bleed. So I was in her room and I was helping to clean up the patient. And as I was cleaning her up, I noticed that she had some like blood clots in her bowel movement. And I asked the patient, if she had any abdominal pain, and she told me that she was feeling some pain. And she, expressed her concerns to me because she told me that she was going to be discharged, that the doctor had just come in to evaluate her and that they were going to send her home. And, she was really concerned and very anxious. And so, I told her, I tried to listen to her, be an active listener, because I could tell that she was really fearful. And I told her I'm going to talk to the nurse and like see if that, I can do in my power. So I left her room and I went out to the nurse's station and I found the nurse and I told her my concerns. I told her that I saw the blood clot, and the nurse tried to reason with me by saying that like her H&H was normal, that the PA had already gone in to assess her that morning. So I told her, I said, the next time we go in, or I asked her if we like, can we go together so that, you could assess her, the so the nurse came into the room with me. When she saw that, she immediately messaged the doctor, and she was not discharged that day. She got to stay another night.
Cool. I really like this story. I feel like you could use it for a couple different things. You could use it for tell us about a time when you had a disagreement with an instructor. Okay.
I had a patient who came in and I had this patient for a few days. So during change of shift, I went into his room to go check on him because I was going to be his tech again. And he had an NG tube in, and I noticed that there was blood coming out of his NG tube. So I tried to arouse the patient. He was unarousable, checked for a pulse, did have a pulse. So I immediately called the nurse, told her that there was blood coming out of his NG tube, that it looked like coffee grain color. And then I also called the charge nurse because I knew that this was a serious situation. So while the nurse was coming into the room, I immediately checked his vitals. His blood pressure was low. It was like 80/50. We called a rapid response on the patient, and I stayed in the room the whole time. It was kind of like a runner to go get things out of the supply room. And we were able to stabilize the patient, and he was transferred to a unit. And
Awesome.
the nurse thanked me after, and she said that she would not have been able to handle the situation without me.
Aw. Did you guys give the patient like blood or fluids or anything? Or
Yeah, they gave him fluid and they gave him blood.
You could say that too.
Okay.
Reverse.
Okay. Yeah, they gave him fluids. I think they gave him like
So yeah, say that like they gave him blood and you guys gave him blood and you guys gave him fluid. That's a really good story. Make sure somehow you work that in. So like,
okay.
A time you advocated for a patient, a time that you had a patient where you had to act quickly, like anything you think it fits for, I would tell that early in the interview.
Oh, okay.
Because it shows that you're ready. So like,
oh my
it's
gosh,
unusual
yeah,
that you like were with it enough to do that even when you were like really freaked out. So definitely tell that story.
Okay, cool.
Yeah.
For our next question, can you please tell us about a time when you advocated for a patient, family member, or colleague?
Yes, there was a time when I did have to advocate for a patient. We had a patient who had a discharge order to go home. And both my preceptor and I, we felt a little bit weary about that order because we knew that based off of the nursing assessments, he wasn't able to do his ADLs independently. He was a fall risk. And on top of that, we learned from his sister, who's his primary caregiver, that the patient lives alone and he wouldn't take his blood thinners consistently. And there would be instances where he wouldn't take his blood thinners for 2 months straight and then proceed to take a 2-month supply in a single sitting. And immediately I identified that to be a huge risk because I didn't want the patient to go home for him to take that 2-month supply and then suddenly fall and bleed out. And so once I recognized that, I realized that the plan of care needed to shift for him. And so I had to advocate for him in that sense, where I had to utilize different members of the healthcare team, where I had to reach out to OT to further look into these deficits that he had with his ADLs. And something really helpful that she did is she conducted a mini cog screen on him, where she found that he couldn't even draw a clock. And we found this information to be really helpful because it illustrated this very objective data for why this patient had these certain deficiencies happening with him. And so because of that, we were able to present this to the doctor, letting him know that we had safety concerns regarding the patient to be discharged specifically going home, and how the mini cog was a case of presenting these deficiencies he did have. And as a result of that, we were then able to reach out to case management, letting them know that per PT and OT, it's best that the patient were to get placed at a SNF unit or a SNF at a SNF rather than being discharged home. And so because of that, we were able to get the patient to be placed at a SNF. And by taking the guidance of PT and OT and really utilizing our nursing judgment, we were able to ensure that the patient's discharge was done in a very safe, appropriate, and a timely manner. And that was an instance of us having to advocate for the patient.
Okay. Just like a nitpicky thing, I think you said deficiencies. I feel like the word they typically use is deficits.
Deficits, yeah.
And then I don't know if it matters though. And then there was a part that you had said you wanted to say last time about that I don't know where exactly you'd fit it in to keep it really streamlined and like a tight answer. Mm-hmm. But the part about how talking with the sister and then like once you did the workup, it really reinforced the importance of not being dismissive of concerns that family members raise and how they can actually be a really important added layer of safety if you
Oh yeah.
listen to what they have to say and like use that to help keep your patients safer.
Mhm. Oh yeah, I know. I was like, I totally realized. I was like, oh crap, I didn't mention that like in my flow. Okay, but yeah, I'll totally remember that now. I was in the patient's room and I was doing an assessment when I noticed that the patient had this left-sided facial droop that was new. It wasn't mentioned in report and it wasn't part of the patient's baseline assessment in the notes or charts. And so quickly, I did a full neuro check just to see if the patient was fully oriented and alert. And I took these findings and I presented it to my preceptor, letting her know that I did a neuro check and I noticed that the patient had a deficit of a facial droop, but no other neuro changes. And because we both quickly suspected that it was a stroke, we immediately called for a code stroke, and I was able to page the stroke team that would then notify rapid response, also letting the primary team know as well. And while I was with the patient, also made sure to take some preventative or cautionary measures, such as checking if she had any IVs to make sure that in case if anything had escalated. And then I also had, because the nursing assistant happened to be there, I also had the nursing assistant grab a glucometer for me and I was able to get a blood sugar, draw some labs as well. And once the team was over, because the doctor was communicating and explaining things to the patient, I just felt that it was a very overwhelming and intense situation for the patient. So I took that as an opportunity to hold the patient's hand just to provide some emotional support as well. And once we were able to perform the appropriate interventions and assessments, the stroke team was able to take over and they were able to bring her down for a CT scan where they found that she indeed did have a stroke. And so that was a case at which I needed to escalate the situation quickly, and we were able to then have the appropriate resource and team takeover, in this case being the stroke team. And so that was the case of that.
Let's see. This is another popular one. Give us an example of a time when you've been an advocate on behalf of a patient.
What was that? It was kind of in and out. I didn't get it.
What
was the question?
Give us an example of a time when you've been an advocate on behalf of a patient.
Okay. Sure. Let me think. Give me just a second to think about this. Okay, yeah. So there was this one patient that was constantly getting his blood sugar checked. Although the patient was able to maintain his blood sugar level, he never went outside the realm every time his blood sugar was checked, and he had good compliance with his blood sugars at home, even outside of the hospital. And, the patient was very compliant with allowing us to continue to do finger sticks every 4 hours. However, because his levels were well maintained, and the patient was having to be woken up throughout the night to get finger stick checks, I went ahead, the patient was asking me, is this really necessary? Everything is fine. I'm totally compliant with my diet and everything. And I said, well, let me see what I can do for you. I understand, I do want you to get rest and everything. So I reached out to the doctor. I let them know that, hey, every time I've taken his blood sugar, his levels have been fine. It's been within the range, and the patient is compliant, and and besides, he's going home the next day. So I was wondering if we can just not do the blood sugars anymore, because he seems to be on plan with his blood sugar levels. And so the doctor agreed, and they DC'd the blood sugar checks. And so then I went back and I spoke to the patient and let him know, hey, we're not going to be poking you anymore. You could get some rest. We will come in and do your vitals as required throughout the night, because I work night shift. And the patient was so appreciative that, he didn't have to continue to get his finger pricked. He thanked me for that, because I guess, he had been mentioning this to staff, and I just wanted to kind of like see what I could do to help get this alleviated so he can have a better rest of his stay.
Okay. I feel like you do this thing at the end of your answers. I can't really put my finger on what it is. It's sort of like you kind of give this look of like, is it okay if can I end here? Is that good?
Okay.
It's a thing that you're doing.
Oh, okay.
Maybe
I'm
like
doing that.
like
Okay.
a confident ending of a sentence.
And that's how I go about, that's how I went about going above and beyond. Okay. That was my way of advocating for the patient. Okay, I'll just do that.
Yeah.
I feel confident in my response, and that's how I advocate for my patients.
Love it.
And this is how I collaborate with other team members. Okay, I got you. Okay, thank you.
But like,
all right.
Yeah.
I can definitely clean that up. Okay.
But like, don't make it like uniform after each one. Like one of them say like, this is what I found is really important to me when I'm faced with that kind of situation, or like how, whatever. I mean, you're good at.
Okay. I can mix it up.
Yeah,
for sure. I'll mix it up.
I don't know
if I'm just saying this because we're doing this mock interview, but I can't recall if I don't think I do that in interviews, but I don't know.
Okay.
But those are good points, good takeaway points. So thank you.
Maybe it's because I'm coaching you, so you're waiting for me to be like, red flag.
What do you think? Yeah, right. What's your response?
What's the verdict?
Give me some feedback. Yeah.
That's probably it.
Okay.